Welcome to the Heart of Healthcare podcast. Hello, listeners, and welcome back to the show. Today, we're talking with my friend, Kyle Armbrester. He is the CEO of Datavant, the largest health data ecosystem in the U.S. Previously, he was CEO of Signify, which he led through its 2021 IPO and later its $8 billion acquisition by CVS in 2023. Before that, he spent 7 years at Athena Health on strategy, corporate development, and product teams. Kyle, welcome to the show.
Thank you. So great to be here.
You have literally been on every side of business. You've grown companies, you've worked on strategy, product, IPOs, getting acquired, making acquisitions, probably like the most diverse background of anyone I've ever known. Can you tell our listeners how you ended up in healthcare in the first place? What drew you into this industry?
Yeah, absolutely. I was kind of a pure technologist for a long time and loved tackling complex problems with technology, and especially where there were areas of administrative burden or inefficiency. So if I could see something could be automated or streamlined, and there's plenty of that to do in healthcare, without a doubt. But what really drew me towards healthcare was I was actually helping Charlie Baker with his gubernatorial campaign in Massachusetts, just volunteering, doing a lot of the tech infrastructure for him. It just sold a company, pure tech company, and wanted to get involved and help him out. I'd met him through someone that was very close to, and he introduced me to Jonathan Bush, who was CEO at Athena Health at the time, and I didn't know quite what to make of healthcare. I was at HBS, and Athena was a mile down the road, and so I started spending a little bit more time with Jonathan. And then around that same time, my grandmother, who was very, very close to, and my father both ended up passing away. And I got thrown into the middle of trying to pull information out of Meditech and reconciling med lists, trying to, coordinate end of life care, hospice for my grandmother in particular. And it was just absolute chaos. And so it was serendipitous almost, if you will, to have had this introduction to Jonathan and the team at Athena, who were trying to spread the cloud-based, Jonathan called it the internet of healthcare at the time, from a really small, medium business standpoint up to bigger enterprises and scaling tech and product and this whole open API mindset that we built out there. And so, yeah, it all came together really in a short amount of time. And that was a very long time ago. And I've, since then decided to dedicate the rest of my career and the rest of my life towards moving the ball forward in the healthcare space and in particular in technology.
Athena Health has such a notable diaspora, including yourself, the Park brothers, like an entire generation of healthcare leaders that have like gone on and done really interesting things. What was it like working there and working for Jonathan Bush, who is he's a very influential, but he's also a polarizing leader?
Yeah, it was the most wild time of my career. I'm not sure it'll ever be replicated. We owned a mountain in Maine. We did big conferences up there with 160 cabins on it. I mean, it was,
Where
he
now
had a vision
he's running for governor of Maine.
for governor. Yeah,
Yeah.
that's right. Yeah, it's funny how that all comes around. But yeah, it was, what I will say about my time at Athena, we were genuinely in the catbird seat of this kind of the internet exploding while also healthcare kind of catching up, meaningful use, which was the democratization of government-funded democratization of electronic medical records across the whole country. All these things were converging at once. And so, we were the cool kids in the street. We could get a meeting with anybody. And it was an amazing opportunity for me just to meet so many folks doing so many amazing things. And I started off there, as you mentioned, in corporate development and running More Disruption Please, which was our big partner API program. And I probably met 1,000 companies in the first few years.
Yeah.
And they were all looking for Rails, right? And it's unfortunately still quasi-similar today, but medical records and practice management systems are barbarians at the gate. Like, you have to get through them to get into the provider space, certainly, and you need to use them to get information out, which is, we'll talk about Datavant in a minute. But it was awesome. And Jonathan had this mindset where he didn't want to do everything. It was kind of almost the opposite of some of the other players in the space, but he wanted to open up and allow entrepreneurs. And I think he was scarred as a younger entrepreneur for a lot of people shutting the door on him and saying no. And he wanted us to not be that way. And that mindset is something I certainly took away. The second thing I would say is, Jonathan and Ed in particular just maniacally focused on the fact that physician costs was basically rising at the rate of inflation, but administrative costs was rising at, you've seen that chart, multiple times that
Yeah.
rate. And let's, protect the physician. Let's not charge them money for not adding value. And let's instead attack that bloat. And that's something I've kept close to my chest through every company I've done, even Signify and Datavant. Like, do not believe in charging clients in healthcare just fees for no reason. Like you have to be either saving them money or making them money or adding some value that's, driving real benefit to them. I just don't think that
Yeah.
a traditional, SaaS platform fee where you kind of hope and hand wave and argue about attribution works. And so I really took that away from my time at Athena. And the last thing I would say was just a wild focus on talent. I mean, we had one of the best teams
Yeah.
ever and just spent, you alluded to it, but so much time recruiting and nurturing talent. And I've taken that with me to each and every one of my companies. And I still have a gang of folks that were at Athena, then Signify, and now are at Datavant, with me. Question their mental health every once in a while for staying with me
Like
this
they need a
long.
sabbatical.
Yeah, exactly.
Yeah.
But it's fun. Like, and
Yeah.
people talk about blind passing, and there's a lot of that at Athena, and this group that has exploded all across healthcare landscape. Like, there's a
Yeah.
lot of trust and assuming positive regard is something we talked a lot about, and I brought that to all my companies since then.
I think for our listeners, anyone who wants to know a little bit more about the Athena Health story, I actually really enjoyed Jonathan Bush's book, Where Does It Hurt? Regardless, the storytelling is really interesting. And this was really one of the early innovative technology companies in the space. So I think a lot to learn and really cool to just see folks stay within healthcare and continue to take those lessons and make an impact. So on that note, let's talk about Datavant. As you know, I've had a +1 ticket to watching this organization grow and evolve. My husband's been on the board for a decade, yet I don't think I
Literally a
could.
decade.
Literally a decade. I know. Very cool. I don't think I could actually confidently pitch the company beyond just this data ecosystem. Can you explain what you guys do for a lay audience, what problem you're solving and how you're solving it?
Yeah, I mean, at the crux of what we do is a problem I have not solved. I'll just go back to some of the root issues that we're trying to move past. When medical records were implemented, the one thing that they did not put in place was interoperability standards or common data frameworks or, like ATM networks have Star and Nice. Like you can go to an ATM in London or New York, pop a card in, and it's going to hit your account. Like no matter who owns the ATM, no matter what card you're using, that type of infrastructure doesn't exist in healthcare. And so that has caused an unbelievable amount of administrative burden. And in particular, I would say, the one thing that happened and that was really exacerbated was we had already, because medical records were paper-based for so long, this whole crazy world of claims and all this post-billing chaos kind of crept up and was digitized before the medical record was to deal with payment. And so when medical records came into the space, they were focused on payment. And Athena Health was very much that way, right? And you have these weird esoteric terms like CPT code and DRG and groupers and all these other things that have really governed and dominated the way that medical, clinical, financial, all data has been moved around inside the healthcare space. And I think at its core, Datavant is trying to break away from those kind of legacy infrastructure constraints and move us into an age where digital, real-time, secure and compliant health information is accessible with authorization and consent to anyone who wants it. And in a nutshell, what we've done, there was a department inside the hospitals and health systems and clinics that has existed for 40 plus years called the HIM department, Information Management Department. And it started off with fax machines and
Yeah.
mailing medical records around because there is no digital interchange. And what Datavant has become is that standard. We are the digital interchange for clinical data in particular across really the entire healthcare ecosystem, whether it's providers, health insurance companies, life sciences companies, legal and attorney, and even patients. And what's happened, the last several years, when I started off, we were about 20% digital. This is over the last 2 years in particular. We're now at about 55% digital. And so we've shown up with a bunch of engineers, done incentives, and really pushed out a digital first mindset. And I'd say two things are happening. One, it is opening up use cases. And so, all that chaos, that billing and all the stuff that I mentioned that sits downstream, it's actually starting to move upstream. And administrative burden is going away as a result of that. And I'll even be more specific. Companies like Smarter DX, which is a sister portfolio company of ours, they are moving way upstream in the value chain on doing coding and clinical data information edits before anything goes to downstream revenue cycle, claims editing, et cetera. And what's happening in effect is like so much of that bloat on the backside. Because again, healthcare is the only industry where you go in, you have no idea what you're going to pay. You have no idea when the bill is going to come. And there's a million different ping pong balls that go on in the
Yep.
middle with payers and secondary payers until that actually gets sorted out. What if all that could be done right when clinical data is captured? And so Datavant's powering that in a big way. The second thing I would say, as we digitize, our other customers are expanding their use cases too. And so instead of just using us for, traditional population health or risk adjustment use cases, we're now seeing vast quality programs, clinical trial recruitment. We've
Oh,
tokenized a lot of the data, means we've linked and connected the data to other disparate data sets. 350 world data partners were the de facto, standard in the space.
like what? What would another data partner? Is it other EHRs or other sources of the data?
Yeah, EHRs are a big one. And we just announced that we're helping Athena Health, going back to my roots, tokenize their data. They've got it all in a
Yeah.
Snowflake instance. But it's really everything under the sun. It is labs, genomic companies, it's claims, so that legacy payment information, it's other EHRs, it is pharmaceutical companies, it's payers, it's consumer companies. And we have the ability to identify and de-identify that data, always with authorization and consent, again, at the core. So we're doing it securely and privately. And so I guess zooming back out, we're leading the digital connectivity revolution in healthcare and opening up more use cases. But in doing so, we are killing administrative burden at scale and really knocking, where we win is when call centers go away or fax machines go away or all these things that should never
Yeah.
exist, and just put friction back on the ultimately the consumer in healthcare. And just really quick on, a sense of scale, we're in about half of all the hospitals and health systems and clinics in the country. And we do the majority of all payer and life sciences volume that are sitting there asking and wanting that data. And we sit uniquely in the middle of that supply and demand. Right. And so we have a data
Yeah.
collaboration platform that can view both sides of the ledger.
And as you said, you work with nearly every healthcare stakeholder in terms of you're working with providers, payers, life science. Maybe you can just tell us, giving those three examples and any other customer segments you want to add, like what is the key value proposition? Because obviously what a payer is coming to you for is very different from a life science company.
Yeah. And that's the trick. Like you nailed it. To digitize, you have to see both sides, right? Because it's not enough to just like digitally enable the source, because the demand side system has its own requirements and its own use cases. And you are absolutely right.
Yeah.
Every single one of them is nuanced, and where we drive a lot of values through the curation and finished product work that we do around the data, and connecting those to the supply and demand. Second, there's a lot of tension between these healthcare stakeholders, right? Like a health insurance company and a provider, like there's frequently tension between the two.
Lots of finger
They,
pointing. Yes.
Lots of finger pointing. They actually need a neutral third party to sit in the middle and just neutrally, blindly using consent and authorization. So making sure we have all the boxes checked, 75 plus steps, in some states. Like it's a really onerous, rightfully so, process. And that's where we sit too. So we're a neutral arbiter of all this information, just move it from point A to point B. And we do a ton of transformation and build all the rails out to enable all that transformation. But we actually don't have agency, right? And we're not selling data, right? We don't like go and buy data, mark it up and resell
Yeah.
it. Folks
You
on
don't
our
even store it, right? You're not
we
storing
don't
the
even
data.
no,
Yeah.
we keep it in our client's native environment, which is what they're demanding, right? We've actually done a lot of work with Amazon, Databricks, and Snowflake in particular, and others, Azure, and et cetera, to enable our services to be launched natively inside any environment. And what's happened was you don't need to build some master data warehouse or master patient index anymore. What's happened with the token and our digitization, you're able to put technology natively in your environment and connect securely, compliantly with consent and authorization to all these other environments, and summon, once you have consent and auth, the right data to solve the problems that you need. The
Yeah.
last thing I'll say, we do play a heavy hand in contract management. And so it's not enough to just neutrally facilitate. They also need a vehicle for payment and, to hold contracts, data use rights, like all of these things. And we do all of that neutrally. Like we don't get involved in the negotiation, but we, make sure that it's seamless for folks to engage in data exchange when they have consent and auth as a part of joining our data collaboration platform.
And Datavant is a B2B company, but most people don't realize you do have a consumer product. You have a white label product that providers can use for their patients. Can you talk a little bit about that?
Yeah, absolutely. Right when I came on, one of the first decisions that I and the board made was to make that product completely free. And so there is a ton of consumer demand, anything from I need a school form filled out for my kids and a medical record attached to it to, hey, I'm changing hospitals or I'm moving or I need to go see another specialist and take my record with me. There's a million different use cases and we facilitate all of that. We have a digital interface for folks to get their information. They don't have to go down to the HIM department that I described earlier.
Yeah.
Instead, they can interface with us digitally. And it's been a huge success. It's
Yeah.
been a big win for the industry too.
And you guys don't take any credit for it. You're not like building consumer brand recognition because you're allowing the providers to kind of take that credit from that product.
Yeah, that's exactly right. And I say this to everybody, and all of our client segments know this, but the providers who we serve are our most sacred kind of asset, right? And they perform the medical care, they have the patients, and we work in partnership with them, right?
Yeah.
It's their data and their patients' data, not our data. And you're absolutely right. We work with them and their brands, especially in their communities, to help drive that. Another interesting fact, we are one of the largest consumers. We are the largest consumer of Epic's Fire APIs. We also push and help enroll a lot of folks into MyChart, right? We're not competing with MyChart. MyChart's a great place to go chat with your doctor, see a result, right? If you just had a test or a lab done. What we provide is, again, access to the comprehensive medical records. You can move it around and digitize it and move it all over the place and move it into any system you need to, not just Epic. And so we're very complimentary, and Epic's been a great partner of ours for many years, and we spent a lot of time with them building out digital connectivity across the landscape.
Can you give our listeners an idea of the scale that you guys are at right now? Are there any numbers that you can share?
Yeah, absolutely. So we're closing our books this year. We'll be north of $1.5 billion in revenue. So we're a larger, organization. Again, been around in our current kind of iteration for almost a decade, as you and I mentioned before. We're in about 80,000 locations across the U.S. on the provider side. So think of that as our supply, if you will. And that's massive hospital systems all the way down to critical access hospitals, in rural communities. And then we have 350 real world data partners. And so all that's the supply. And then on the demand side, we have payer, life sciences, and legal and attorney are our big kind of verticals that we serve. We obviously do patients, as you alluded to, but we don't charge money for that. And we are the number one player in each one of those markets, serving, I can confidently say the majority of all of the demand side requests from those segments come from us, even if it's not us on the supply side, right? And so we'll go work with a hospital trying to run their, data exchange on their own and help them digitize, even if we're not staffing and running the whole thing for them.
Okay, let's talk about data. I have like an entire chapter in my upcoming book on data and the fact that we have this really odd problem of data being both misused and underused in healthcare. So I want to talk about both of those things, starting with misuse. And when I say that healthcare data is misused, I mean very literally misused as in stolen. We all remember when United Health paid $22 million in Bitcoin ransom to Russian cyber criminals after their cyber attack shut down their operations at clinics and pharmacies for over a week, ended up costing the company over $2 billion. And that stolen data, for all we know, is like still out there. Why is the healthcare sector such a prime target for cyber criminals?
Yeah, I would say three things. One is the value, the ability to grab healthcare data. It's more valuable than credit card data. It's one of those areas where your willingness to pay exceeds your capacity to pay. And so if you have the ability to market or know what individuals are going through, like it's wildly valuable to a whole bunch of stakeholders like out there. And many of them, especially in, other areas of the world, are willing to pay for that data where there's less privacy and less IP controls, et cetera. So there's a lot of value. Number two, wildly antiquated systems. I joke with Jeff all the time, like, you don't even have to be a great technologist in healthcare to make a hell of an impact because the bar is so low with so much of the legacy infrastructure that's come across. And I think that, a few things cause that to happen. One, I think HIPAA regs are very, 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 that's a very high bar. We need to relook at HIPAA as a society. And I can tell you, like, having worked with providers for a very long time, if you put a HIPAA waiver in front of a patient, they sign it, like every time. Right. And so what really are we solving for? And so I think we need to bottoms up, what HIPAA is and have it keep pace with technology and the change and some of the work we're talking about. And I think it's constrained systems more than helped them because it's not actually solving the root underlying problem. The second thing I would say is, because of the way healthcare data moves around and is stored, in all these stored procedures and legacy systems and legacy infrastructure across the environment, it is very hard to actually quantify risk. And so a big thing that we do with all of our clients is we, spend north of $50 million a year on with our CISO, our Chief Information Security Officer, and his team going out, not only securing our own infrastructure, but doing that with our clients as well. And if I had to tell, you or anybody what we ultimately sell, it is trust and security, right?
Yeah.
We're moving very sensitive, very expensive, very valuable, data around. And it's something that we take very seriously. But unfortunately, like I think until we push and mandate, and I think high trust has been a good foundational movement, more at a federal level. This is where I get frustrated when I see the government weighing in on things like TEFCA and interoperability standards and regs, like put incentives in market and drive behavior. But let's ramp up, penalties for information blocking. Let's ramp up penalties for cybersecurity breaches, right? Like
Hmm.
put out incentives that'll drive behavior and allow innovation in the market. Me and my team spent a lot of time in DC pushing and showing and demonstrating, paths forward. The last thing I'll say, technology has caught up in a big way. The technology sector has figured out that healthcare is 25% of GDP.
Hmm.
Amazon, when I was at Athena, AWS, you couldn't get them to sign a BAA, a business associates agreement. So you could store PHI securely inside an Amazon environment. They do that at scale, now
Yeah.
today.
Now they're
Clouds,
acquiring companies in the billions for,
yeah,
yeah, in the
you know,
space.
CloudStrike's got a big healthcare presence, Databricks, Snowflake,
Yeah.
all these organizations have come in. So the infrastructure is available now, which was not the case 10, certainly not 10, but not even really 5 years ago. There needs to be a big modernization effort of a lot of these legacy technology platforms that sit out there. And I think
Yeah.
that, Optum, who's a very large client of ours, like they're going through that at scale after the change breach that you just mentioned and have
Yeah.
been spending more money than ever, attacking that problem.
Getting up space. Okay, so you said we need to relook at HIPAA. What would you recommend is changed or updated?
Yeah, look, I mean, not tooting our own horn, and there's other options out there, but tokenization and like these concepts of privacy enhancing linking technologies did not exist, weren't even formulated when HIPAA was originally constructed, right? And
Mm.
I think it's every time I've gone to DC, you get consumer advocacy groups pushing HIPAA at a million-foot level without getting to the nuance of technology change. And I think we've got to bridge the gap there, and make it to where we take a look and do a refresh, probably regulate a refresh of HIPAA every so often, given how fast the pace of technological change, is happening in the market. The other thing that I think we have to improve federal coordination and communication of cybersecurity incidents and near misses when one or two records go out, or it's going to happen, right? Like we need to you can't protect everything, and we need to make it so folks feel comfortable and safe, especially some of these hospitals and other organizations who don't have all the resources necessary to do all the upgrades I'm talking about, and federally fund the ability to start to upgrade our infrastructure. I think it's a national security conversation. This is not just a
Yeah.
nice to have, and we need to start treating it as such.
And you think it can change with the current
Yeah.
administration?
Yeah, I think it can change. I think it's the good thing about healthcare data and healthcare data regs, it has transcended many Democratic and Republican administrations. There's no one's going to argue with you against it. The bigger problem though is you need probably an 8-year admin to get some of the changes pushed through because there's so much
Mm.
turnover inside CMS
Yeah.
and CMMI and some of the other vehicles right now. But a lot of the, staffers and folks who have been there for some time are moving the ball forward in a great way. And I think that we've had more conversations with the federal government in the last 2 years or so since I've been here. FDA, CMS, HHS, all over the map, with them starting to think about more modern tech and going out and reaching out to constituents to start to answer this problem, that you and I are laying out right now.
Yeah. So, okay, back to the data misuse and underuse problems. So, underuse, there's some estimates that about 97% of healthcare data remains untapped because it's in isolated, unstructured networks, closed ecosystems. This is obviously like the core of your mission and what you're doing. In your view, where is healthcare leaving the most value on the table when it comes to data?
Yeah. So much of it, the number one in my view is just the way we capture information, right? And so if you've got a medical record system that is predominantly designed for billing, it is going to be billing focused on the inputs and outputs, right? It's worried about coding and it's worried about reimbursement. And
Mm,
so the other, information that's captured largely goes into an unstructured bucket and it sits there. And it's very hard to clean it up. It's very hard to transfer it if you switch general practitioners or if you're going to a specialist. Next, you have imaging, and imaging systems are largely disconnected
yeah.
from this stream of data that I'm mentioning, and they're very valuable. I do believe a very strong use case of artificial intelligence is going to be at the very least summarizing all this information in a clean, concise, statistically significant way where a clinician or a lab tech or whoever on the healthcare delivery supply chain can have better information at their fingertips. The other, you know, top of mind thing for me is the med list, right? One of the things we did at Signify, we would go into these, predominantly seniors' homes and say, all right, give me everything you're taking. Get it me from, the bathroom, medicine cabinet, get it from the fridge, your bedside table. Like, let's lay it all out. And that was the best med list ever, right? Because it wasn't what they were prescribed. It wasn't what they remembered to
Yeah.
bring to the doc. It was like what they were actually doing. And we got to see seniors splitting pills because they were, it would hurt their digestive system or they couldn't afford,
Yeah.
the full pill every day. And so that's like a real med list. Getting closer to that from a consumer centric standpoint at scale is absolutely critical for us bending the cost curve and driving, better outcomes. And reimbursement centric medical record does not have that at the heart of its
Yeah.
mission or charge. And so again, like if I was running CMS for a day, like figuring out incentives and vehicles to get that level of med list like pulled together and with consent and authorization spread to providers, drug on drug interaction and all the other drug issues I just mentioned are huge things that go really untouched. And pharmacy has been largely pushed out of the kind of central care team.
Yeah.
Historically, that's starting to change in a lot of places. But tackling that problem, I think, is one that does not get talked about enough. And,
No,
it's,
it really doesn't. And do you feel like that is more possible within like a value-based care world where if your patient population is under a capitated model, you have more incentive to kind of track at more of a patient-centered level?
I don't even know what value-based care means anymore. Like, unfortunately, like
Okay, you're not being paid a flat capitated fee to
yeah,
manage
yeah,
a patient population. In that case, you would imagine, a billing based EHR isn't as important as
yeah.
one that is like clinically more relevant.
Problem is all the EHRs, especially the ones at any of these
Yeah.
hospitals, are so billing centric. Like, so what do? You buy
Yeah.
wrapper software like Arcadia and others that sit around the whole thing, and it's logging into different screens. You've got an overlay. I just don't think it's been cracked like at its
Yeah.
core. And I'm a broken record on this. Like this, the new models that are coming out right now, they're not paying enough money to primary care physicians. Period. And you're not going to get behavior change until you rip the band-aid on incentives and drive alignment downstream. And we are too scared as a society with, negative incentives and influencing behavior and all these other things. And instead of actually like taking more risk and pushing, an agenda that is patient centric, which is what you're articulating.
Yeah.
I think we've gotten ourselves wrapped up in a constraint centric point of view versus taking risk and experimenting with reimbursement, in particular to see how we can drive better change. But the systems are a real constraint.
Yeah.
The systems of record are a real constraint inside of that
Yeah.
today.
No, absolutely. I mean, as you talk about being like focused more on reimbursement and billing, like of course then the product is health data that is about billing codes and not necessarily about like the actual patient experience. I'm just like brainstorming out loud here with you. With now the proliferation of ambient scribes, we are capturing more of the encounter than we have ever done before. Do you think that could be a push in the right direction for having data that's like a little bit more, able to be parsed and inclusive of clinical information that doesn't exist today or
Yeah,
doesn't exist yesterday?
I wish I could say yes without a doubt. I'm hopeful,
Yeah.
is what I would say. But as I've gotten on the ground and spent some time around the ambient space, like, first of all, transcription and scribing's been around for a very long time. And there's people that were physically listening into the encounter and just
Oh, yeah.
typing it out.
Oh, yeah. We back dogmatics at Raquel.
It was amazing. Yeah, and they were very early to the space. And so I've seen it around. When I sit with docs, and I do it frequently because we're like so deep in the workflow and we work with them, they've got macros, they're copying and pasting. Their method of data entry is very efficient depending on the encounter. And
Yeah.
so I'm not sure there's going to be some, and if you really peel back utilization statistics on the various ambient providers, they're all over the place and it's very specialty centric. It's very health system centric.
Yeah.
Do I think it net makes the doctors feel better? Without a doubt. I mean, look at the growth and the kind of explosion in that space. Like without
The
a doubt,
adoption is
like it's,
incredible.
yeah. But is it going to solve the problem you're talking about? I think we need more time.
Yeah.
Is the answer to it. And I think, look, like that space is under a lot of pressure. You've got Epic and Athena basically saying, and others, we're going to do this for free. Like this is going to be a part of our, native EHR system now, which puts all of the third parties like in the space in a really interesting space. So if the price goes to zero, where do they need to get the money from? What it has to be the payers, life sciences, other providers who need that information. Like you've got to go back out to the ecosystem. But the second you do that, you're putting more administrative burden back on the doc, right? Because
Yeah.
they're needing to think about another billing code or another clinical trial enrollment or whatever it might be. And so it's not a problem that I think is an easy solution. I'm very hopeful though that that space is the path forward to taking some of that documentation burden off of providers because they spend an awful lot of time, on it
Oh,
today.
yeah. Oh, yeah. And so let's talk about your job. Being CEO is the hardest and, in my opinion, the worst job. You're clearly very, very good at it. What part of the job do you love the most?
I'd say it's two things. I love rolling up my sleeves and getting out with the customers and putting a headset on, like sitting in the medical record room, understanding, with the discovery team on a life sciences client, how they're recruiting patients and where they're running into problems. Like, and I push on my team constantly that direct, especially in healthcare, like customer experience, like there is no shortcut and no two organizations are the same. And so you have to physically
Yeah.
spend time and re-implement yourselves. Like you can't launch a product in healthcare and expect it to be static. Like you have to be on some routine cadence of updating and reintegrating, and change is just a constant like inside this space. So I love
Yeah.
that. And two, I love my teams. Like, and I mentioned so many of them have, come from outside of healthcare backgrounds, and so many of them have been with me for some time. And, I've enjoyed a lot of the folks that when I was younger in my career, I had a lot of great mentors and people that invested in me. I love doing that with folks now too. And I try to, design my organizations and create them when we scale to still have that kind of human centric mentoring and nurturing model at their core. And
Yeah.
I think when all those things are happening, like you have fun. And I think having fun at work is super important because there's, especially in healthcare, a lot of chaos and challenges on an everyday basis that you face.
Yeah. I think people, especially MBAs like us, the role is like romanticized to us. It's almost assumed like the CEO is that goal for you in your career, but it's really not a job for everyone. What would you say to people kind of early in their career who are thinking about their trajectories of the companies that they're working at or starting?
Yeah, it's the most full-time job there is. Like, I think you have to be willing. I say this to my management teams too. Like, we are responsible for a massive pool of consumers and healthcare organizations, and healthcare is 24/7. And there's sometimes like you're just going to have to be on. You can't just close the laptop and just ignore what's going on. And so that's a sacrifice, right? And that's a decision that has to be made. Two, and my father-in-law will love this. He was a professor at HBS for a long time. He was
Yeah.
very early on in the organizational behavior unit, but it's a whole bunch of people management, right? And people are complicated and it's messy and they're emotional and they have their own priorities and their own lives. And so I think leading with heart and, paying attention to folks and their, motivations and what they're trying to do, both clients and employees, it's a
Yeah.
lot. And if you are not up for that type of engagement, I think real success is tough. Like there's a lot of CEOs that just choose to sit on top and do not do the two things I talked about.
Yeah.
And those are very different organizations, I think, that have very, statistically different outcomes, right? And I think that
Mhm.
leading in a human-centered way like that, both with clients and with your, individuals you work with is super important.
Yeah. I actually found that out as CEO that like the people management piece was not congruent with what I was good at or what I wanted to do. I wanted to do the work. I enjoy doing the work. I love thinking through the problems. I love getting my hands dirty and solving the problems, but actually as CEO, you spend most of your time on people management. And if that is not your thing, if it is not like your biggest skill, then you're probably not the right one for the job. But you've now led a company through IPO and acquisition and acquiring companies. Most CEOs don't get those privileges. Given those two experiences, the IPO, the acquisition, which one was actually harder to navigate?
The IPO, without a doubt. public markets are the Wild West, and we beat and raised our financial projections every single quarter that I was CEO, and just an amazing
Yeah.
team. And our stock went from $40 to $11, during that time. So like almost a 4x like delta. And it's very
Due
hard to
to
manage.
due to the market sentiment,
Yeah,
due to
a
what
bunch
was
of
the
healthcare
yeah.
companies went public, and some of them shouldn't have been companies. Some of them should have never gone public. Some of them are never going to make money. And so, who to compare you to is big when you're public, and that's very hard
Mm,
to educate employees on when all your metrics are green and going up, and everyone's working so hard.
yeah.
So it's a very tough spot to be in managing a team. I actually think public markets are more designed for large, diversified businesses and businesses that are more well known and understood, kind of in market, or something that's truly breakout disruption, like this whole AI craze that's going on right now, where
Mhm.
there's so many data points and use cases and examples. I think public investors need more of that. And so I'd say that volatility was way harder to deal with in the acquisition. The acquisition was a lot. Like, I don't want to downplay it. We had 21 folks bid on Signify. I lived in
Wow.
a hotel room for weeks in New York, just dry cleaning my clothes, going back to Goldman Sachs every morning,
Yeah.
like it was the Groundhog Day, and repeating myself.
Oh my gosh.
CVS was a
Yeah.
great place to land, an amazing management team. They're still a very large customer of ours. And I had a great time there. I spent almost 2 years there, learned a ton, and, believe they've got a great platform to help really improve the consumer experience ultimately in healthcare. And so I was very happy for Signify to land there. It's where I wanted Signify to land, of all the folks that were out there. And I
Yeah.
will say, like, even though it was a great financial outcome, like, when we came to the crossroads of deciding, like, it's a very personal decision for you as someone who's worked at a business so long, and all the employees and all the customers and all those relationships of where things to land. Like, at the end of the day, those things matter the most. And so
Yeah.
I was very happy, and I've been very happy to see CVS continue to invest in Signify. And we beat every number told them we would deliver them. And, that's a part of
Yeah.
my and the team's reputation. And that matters a lot to me as well.
Totally. Yeah. So, Kyle, this has been a great conversation. I always like to end the show by asking people if they could wave a magic wand and change one thing about healthcare, what would it be?
But I think for me, it would be having incentives really changed and ensuring that let's define the behavior we want, whether it's information sharing or it's, as you alluded to, a more value-based centric approach where payment and risk and clinical information is all bundled into one infrastructure build out. Whatever those things are, I think we need to be way more bold at experimenting and relax, some historical notions of technology and alignment and market players if we're going to get out of this current, frankly, mess that we're in, right? The Medicare
Yeah.
trust is in distress, period. And we've got providers that are burned out. And if
Yep.
we're going to get past that, we've got to really start thinking outside of the box. And, I'm hopeful CMMI can get there again. I feel like under Patrick Conway, there was an explosion of innovation and new models coming out. Their ability to price things and to transparently price things, I should say, is difficult because of system limitations and a whole bunch of other factors internally.
Yeah.
We've got to strip those things away because it's keeping capital and innovation away from those programs today. And I look, the government's the largest payer in the United States, and it will be forever.
Yeah.
And we need to make sure that we keep removing constraints around its ability to innovate as well.
Yep. Awesome. Well, Kyle, thank you for your time today. It was great to see you.
Yeah, great to see you too. Take care.